Let's see. First, a couple of housekeeping issues. It's requested that folks introduce themselves, especially the first time that they speak. We do need to take roll call votes on every action item. And folks should be aware that the meeting is being recorded for the minute-taking purposes. And as well as posting of the recording on the proceedings on the agency's website. So with that, Marcin, I will turn it over to you for the roll call for attendance, please.
Yes, Mr. Chair. Tiro Dolittle.
Here.
Okay, thank you. Cece Woods.
Here.
Deb Poland.
Here.
Sheldon Tubman.
Here.
Kevin Galvin. Karen Siegel.
Here.
Giselle Carlotta McDonald.
Here.
Leslie Greer.
Here.
Holly Hackett. And Mr. Gerald O'Sullivan.
Here.
Thank you.
Thank you, Marcin. So if the members of the AHC senior leadership team could introduce yourself, please.
Sure. Good afternoon, Mr. Chairman. This is James Michelle.
Hi, Rebecca McClear, Director of Technical Operations and Analytics. Caroline Lee Ruette, Director of Marketing.
Tammy Hendricks, Director of Health Equity and Outreach.
John Carbone, Director of Small Group and Product Development.
Louis Irizarry, Outreach Coordinator.
Okay, is that it for the staff?
Ellen Laramie, Outreach Coordinator.
Oh, sorry.
Sorry.
If we'll continue with the staff, Martin Lechowski, Governance Specialist, Access Health Connecticut.
Karen Perez, Outreach Community Manager.
Mr. Chair, there was no public comment submitted.
Okay, great. In that case, I would move to the first order of business and would solicit a motion to approve the October 27th, 2022 special meeting minutes. Motion for purposes of discussion.
So moved. Cece Woods. Second. Deb Poland.
Okay. Is there any discussion on the motion? Hearing none, as I mentioned, we do have to do a roll call. So Marcin, could you please proceed?
Yes, Mr. Chair. Tiro Dolittle.
Aye.
Cece Woods.
Yes.
Deb Poland.
Yes.
Sheldon Tubman. Kevin Galvin.
Yes.
Oh, Ms. Dub. Okay. Karen Siegel.
Yes.
Giselle Carlotta McDonald.
Yes.
Leslie Greer.
Yes.
And Holly Hackett. Thank you. Motion passes.
Okay, great. Thank you for that. We'll move on to the next item. We're going to hear from James Michelle, our CEO, about the committee's role. Please go ahead, James.
Thank you, Mr. Chairman. And first, let me express my thanks and appreciation to this committee. It's a critical committee for Access Health in that we get access to community leaders who are very close to the individuals that we are targeting to get them access to health insurance to improve their quality of life. To do that, the members of this committee represent a variety of organizations throughout Connecticut in the areas of health equity, community serving organizations, navigator organizations, brokers, and members of the Access Health Connecticut. Through these meetings, we hope that the committee members will provide us guidance in the following areas, in the areas of health equity, including the Broker Academy. Outreach efforts. We have, over the last 2 years, again, Tammy's going to talk a little bit about the work that she's currently doing in preparation for the unwinding of Medicaid. However, this committee was created about 2 years ago, where after a health disparities study was conducted by Access Health, we realized that the people who are currently uninsured, impacted most by health disparities, they're the hardest people to reach, right? Because they are in communities where there's a lot of reasons why they don't engage with government entities. So we have to create an organization that's going to go into these communities and engage them directly, but also leverage partner organizations who are already embedded in those communities that we could use their trust and along with ours to get access to this population, answer the questions, to develop a trust going forward. So this committee gives us access, informs us as to exactly how to go about doing the outreach effort that Tammy is focused on, her and her team are focused on. And also, many of you are very close to the consumers that we are currently engaged with. Again, both our current customers as well as future potential customers. We think because of your relative proximity, close proximity to these consumers, you gave us insight as to best help them when they have challenges, when they come to Access Health. How do we best help them to maintain their health, but also get access to health, continue to get access to health insurance? So we think that this committee's role is critical. That if we stay focused in these critical areas, this committee could have Access Health to become very, very efficient and effective at helping those who are dealing with the greatest challenges in their lives on a regular basis. So we look forward to really your input, you challenging us to do better, to help this population to move forward. Mr. Chair, this concludes my statement. I'm happy to answer any questions at all. If anyone has any. Thank you.
Any discussion on James's comment? Please go ahead.
Can I just
Karen,
ask clarification that the committee scope isn't limited exclusively to outreach, is it, or is that what you're saying?
No, absolutely not. Education. We think that if you have ideas and thoughts of things you can do differently, better, but that would make us more effective, more efficient in terms of engaging with the population, especially the uninsured. We are all ears. Again, this can be done in the areas of we can improve our technology, do more targeting marketing, as well as in-person outreach. So everything is on the table for this committee.
Okay, I'm asking for clarification in part because at our first meeting, we had also talked about opportunities to advance equity through procedural change and through benefit review or benefit design. And I just wanted to clarify that those issues are also still potentially within the scope here.
Yes, a number of you are on the Health Benefit Qualification Committee. This is the committee that looks at the plan designs and makes recommendations to the board. Your chair is on that committee, and there may be one or two other members. One of this committee's members may be on the HPBQ as well. So if you have any ideas on how to enhance or to help address health disparities through plan designs, bring them up, we'll document them, and we will share them with the HPBQ committee when they meet.
Thank you.
So,
I hope that was helpful.
yeah, I mean, I don't think, obviously, there is a health benefits design committee specifically, but there can be some interaction there. I would urge folks to remember the consumer experience part of this committee, and that includes things like the website interface, how to make that better, call center experience, those types of things. and those, of course, bleed over into equity as well. But I do want us to be focused on the actual consumer and customer experience. For shopping, we're good, but there's a lot of improvements out there that we could be recommending to Access Health. So keep that in mind as well. Anybody else want to add something? Sorry, James, if I cut you off, go ahead.
Quickly, from a consumer experience perspective, to add to what you just said, Ted, we are looking at health literacy, enrollment assistance, and year-round assistance to help consumers use their health insurance to improve their health. So any of those ideas that you have that could help us achieve those, please let us know during these meetings.
Okay, does anybody else wish to comment? All right, with that, let's move on to item E, the further update on the Medicaid unwinding preparations. If you would go ahead, Rebecca McClear, Caroline Rouette, and Tammy Hendricks, go ahead.
Great, thank you. So we'll start, Rebecca McClear, the Director of Technical Operations and Analytics. Some folks may have been part of a conversation over the last few weeks on this, but we did want to just talk with this group and let you know the preparations that have been underway for the past 12 months or so for Medicaid unwinding. So the Medicaid maintenance of eligibility provision, or the Medicaid extension, as we sometimes refer to it, will end on March 31st, triggering potential terminations of Medicaid coverage for some folks starting at the end of April. So the slide you're seeing here does have a lot of information on it, so I'm not going to speak necessarily to it, but I'll try and explain what you're seeing there. So based on this data, which was taken at the end of January, there are about 430,000 individuals currently enrolled in a Medicaid program who are considered part of this Medicaid extension. So what that means is these are folks who were on a Medicaid, enrolled in a Medicaid program, and at some point since March of 2020 have reported a change in the system that traditionally would indicate that they were no longer eligible to remain on that Medicaid program. Due to this extension, those folks were not removed from their Medicaid program and therefore retained their coverage. So starting in April, DSS has looked at this population, and we are spreading out the individuals, basically starting with those who have been on this extension the longest. So folks that reported a change back in March or April of 2020, and their Medicaid coverage would have ended at that time. That's the first population that's going to be reprocessed to potentially come off of their Medicaid program. Okay, so you'll see that this chart is month by month. It talks through how the potential volume of number of individuals that will be processed each month to be redetermined, potentially to remain in a Medicaid program, potentially to no longer be eligible for a Medicaid program and then have to come back in to select a QHP plan. Okay. These volumes, these individuals are going to be added into the normal, kind of loosely, the regular Medicaid renewal cycle, so monthly renewal process that we've been doing for the past 10 years. So the volume is increasing of what we process each month. DSS has been working over the past year to review their process and with the goal of trying to ensure the most or the largest number of individuals remain eligible for their program, if appropriate, within the guidelines that they have. So they've done a lot of work ensuring or increasing that number of what we call the passive or auto renewal population. Prior to this, historically, the percentage of folks that processed each month that were successfully auto-renewed without any manual intervention into their Medicaid program was about 50 or 60%. Based on what we're seeing now with the changes that have been made in the system and the process improvements, they're anticipating a 70 to 75% success rate for their passive renewals. That's 70 to 75% of any of the folks processed in their monthly redetermination process that would be successfully re-enrolled into an appropriate Medicaid program without any intervention by the consumer. So that's great news. You know, that's a big bump, a big increase from where we were before this work started. So given that information and given our number of about 430,000 folks as part of this extension, we're looking at about 70 and 75%, so about 330,000 of those individuals we're projecting would be re-enrolled into a Medicaid program. Now that's assuming that everything in the system remains the same and is accurate. We know there's a lot of folks who haven't come back in to update their income or update their household situation. So just knowing what we have in our system is what we're using to kind of do these projections. Those folks that aren't redetermined to be eligible and re-enrolled into a Medicaid program, and those folks, we looked at their income levels, strictly about income based, and we looked at about, let me find my number here, about a third of that population could qualify for to enroll in a covered Connecticut plan to select that. So the remainder, their income in our system currently does not qualify for them, but they may qualify for some financial assistance in the form of subsidies. But the main point I want to make is those folks who are not determined eligible to remain in their Medicaid program must come into the system to select their QHP plan or potentially update their information. Like I said, they haven't come back in 2 or 3 years. It may not be at their current income level, may no longer apply. If they come in, they update their information, we may find out they become eligible for Medicaid. So DSS has been doing a big marketing push, and Caroline will talk a little bit about that to get them to update their information. Because folks, again, if their information is updated in the system, then when they're processed through this redetermination process, they're more likely to be redetermined appropriately and be able to maybe be re-enrolled back into a Medicaid program if their income has changed. So that's kind of, do you have another follow-up?
No, just quick comment. I just want to summarize. So Sheldon has his hand up. Just going on, look, we've estimated about 434,000 current Medicaid recipients out of about 920,000. Will is who is part of the Medicaid extension. All right, of that amount, 334,000 of them, we are again estimating will remain in Medicaid. They will not have to do anything at all. They will retain the coverage they have now. The balance of about 100,000, about 30,000 of them may qualify for Cover Connecticut, which means that they will have no cost health insurance for the next year. The balance, most of them will qualify for QHP, so that's about 65,000. So again, the only people that we have to process, we found is that 100,000. That's above and beyond the folks who will automatically be renewed back into Medicaid. So the amount of energy and time resources that we need to do that is far less than expected, especially when we consider that this should be done over a 12-month period. And we normally do about between 105 to 115,000 within 3 months with open enrollment. Now we have to do about 100,000 over the next 12 months. So we think that we're in a good position to handle the renewal process, given that almost 75% of them will be automatically renewed back into Medicaid over the next 12 months. Mr. Chairman, concludes our comments with respect to the unwinding of Medicaid data.
Okay, thank you, James. And I know that Sheldon has a question, but before we move to Sheldon, I would like to ask a question. So with respect to the largest group here, the ones that remain eligible for Medicaid, we've been saying they're going to be automatically re-enrolled. Can somebody walk me through the actual consumer experience of somebody who is going to wind up in that 334,821 number? Obviously, that there's going to be a lot of different experiences in there, but typically, what are they going to experience? Are they going to get a letter that then they don't have to act on? Or I just want to know exactly from their perspective, what is going to happen for them to move from the initial redetermination to safely into the folks that have been automatically re-enrolled? What does that look like from the consumer experience perspective?
Sure. So as I mentioned, those folks will be absorbed into the regular monthly Medicaid renewal process. And in general, what happens there is about 60 days prior to when their Medicaid coverage will end, they'll get we'll run a projection for them, and they'll get a notice at that time. And that's what the timeline is in that first column. So we'll talk about our April 30th batch, right? That first bucket. And so their coverage is currently planning to end on April 30th, their current Medicaid coverage. So the first week of March, they'll get a notice that lets them know everything based on our system. Here's where we project you will end up. You may qualify for this Medicaid plan, you may qualify for the TMA, or you may no longer qualify for Medicaid, and you would have to come in and update your information and shop for a QHP plan. We'll also give them again, based on what we know in the system, an idea of what their QHP eligibility might be. Based on that, you could be eligible for Covered Connecticut, or you could be eligible for a subsidized program. The next step in that process, sorry. Go ahead.
So if I'm one of the lucky folks who is going to be eligible, I'm going to get that initial mail notice, and it's going to tell me it looks like you're eligible. Just don't do anything more, or what after that initial notice that tells them that they looks like they're going to remain eligible, what, if any, touches is that person going to get?
Then if the individual gets that notice and all their information is accurate, then correct, they don't have to take any action. If the information is accurate and they're projected to re-enroll into a Medicaid program, technically they don't have to do anything at that point. If information is inaccurate, they need to update it. They can come back into the system and update their information so that that final projection, which is run in mid-April, which will then take action, will be most accurate. Now, in that second step, which is the second column, that's a redetermination that's run. Again, it's based on what's in the system. So if they haven't updated it, it should have the same result as that first letter. But if they come in and made a change, then that end result could be different. At that point in time, we call that our final determination. That letter is basically at that time saying, here you are being renewed into this Medicaid plan. You are able to be enrolled into TMA, or you're not able to, you're eligible for this QHP product. Here's your eligibility. Come to our system, contact us, and enroll in that plan. And then they would have the 60 day, they would have the timeline, they would have a 60-day window to do so. DSS, I don't have all their plans, but I believe they do have some plans in place to do some outreach to this population along the way outside of the system. I do not have the details of that because DSS is coordinating that. I don't know if we have anything more.
Okay, thanks.
So
That's helpful. Yes, that's very helpful. Thank you. So Sheldon had initially raised his hand. I don't see it anymore, but if you still have a question, Sheldon, go ahead. Then I saw Kevin Galvin, and then I saw Karen Siegel. So in that order.
Yep.
Sheldon?
Yeah, I do have, sorry, I still see my hand, so I don't know.
Okay, I just don't see.
But so I have a lot of questions about this. I'm sorry. And before we get to that, I wanted to know, is there anybody from DSS on the call in the minutes from the October meeting? There was discussion recognized about the need for DSS here because there's so much interaction. Was there any communication with them about participating?
Martin, did we reach out to DSS to be part of this meeting?
The DSS has not been part of this discussion at this point.
Right, but
So-
what we
so
agreed at the
then-
last meeting, sorry. To reach out to them. The idea was to reach out to them, and if the answer is no, there's been no reach out, there has not been. But here's the questions I have about this slide. The first big question is, does this include the non-Magi people? Is this an overall slide about the number of people who, the 430,000 who were kept onto the unwinding and have to get re-reviewed? Or is it just the Magi groups? And then I have several questions, and you'll see they're all related. That's the first question.
Okay.
The second question is, there's a missing column here, which is the people who are not, I think, that they're not automatically able to be re-renewed, but they get renewed on Medicaid anyway after there's some communication with the person. And that should include not just Medicaid that they're on, but some alternative Medicaid. And that could include, for example, going from Magi Medicaid to non-Magi Medicaid, or it could be they're now pregnant, and so they're the higher income level. There's a lot of different things that it could be, but I don't see a column that estimates the number of people who are going to be reached out to and who are then, and this is required by federal law, you have to do this, and it was just sort of alluded to in the description there, but going through the passive enrollment thing, if that doesn't work, that's not the end of the line. You're now required to reach out to the person and say, okay, give us all your information, see if we can find if you're, otherwise eligible. And that would include, for example, they're now disabled and working and therefore qualify at $75,000 a year for Medicaid. So I just don't see where that's in this chart. And maybe it's because this chart is only the Magi groups, but even if it's only the Magi groups, you also still have to be reaching out, and presumably there'd be some people who failed passive, but when you reach out, are found to still be eligible for Medicaid, some kind of Medicaid. And then my last question, there's a lot of questions here, and I apologize for that, but this is really important stuff. How do you, when you reach out, if you find that they might be eligible for Medicaid that's not run by Access Health, but by DSS, namely non-Magi, which could include Age Blind Disabled, MedConnect, what is the process there?
So let me try and tackle those for you, Sheldon. So first off, you're right, this only addresses or includes the non-Magi population that is part of the extension. So I believe that's A and, oh, sorry, yeah, reading my notes wrong. It includes Medicaid A and D. It does not include C, does not include those programs that are managed by DSS outside of the Access Health system. And so that kind of answer trickles down to a couple of the other questions. DSS, I know, they're responsible. This is their population, and part of their plan is to reach out to those folks who are, for lack of a better term, that failed to be auto-renewed or passively renewed back into their Medicaid plan. They have a process in place currently that they will be continuing and expanding on to reach out and work with those individuals to update their information, verify their information, and determine which program, whether it's a Medicaid program that they can be re-enrolled in because their information's changed or what have you. DSS has a process that their team is responsible for doing to ensure that they get re-enrolled or enrolled into the appropriate program, whether it's Magi or non-Magi, depending on their eligibility. So DSS, again, it's something they do normally. They're continuing that and expanding upon it based on the size of the population and the changes to the regulation. That I think that kind of gets to a couple of those questions as far as why we don't have an estimate, a number for what that population could look like, that extra column you're talking about. We've talked with DSS, and I know they are working on some numbers of what that population might look like. The concern there, like I said, that a lot of that is outside of our population, and they're trying to determine that benchmark of what that would look like for a conversion rate, because historical numbers versus current numbers are a little bit different. And remember, again, this is just in addition to the normal monthly course of business for Medicaid renewals that's been going on even prior to the PHE.
Thanks. So do I understand what you're saying is that if passive enrollment, this chart is, I understand, only for Magi, but if passive enrollment does not work, it's going to be DSS, even though we're talking about Magi now, it's going to be DSS, which is going to be doing the follow-up to ask them for more information. Do I have that accurate?
Yeah, because they're a Medicaid, it's still a Medicaid individual. So if they are determined not to be eligible, right, they get the letter that says you're no longer, based on the information you have, you're no longer eligible. Then DSS they have a process where they then follow up with depending on why they're not eligible, right? If they're not eligible for income, they have one set of processes. If they're not eligible for some other reason, they have other processes. But yeah, I'll defer to outreach and marketing. Caroline and Tammy may have some other avenues and other messaging that they're doing, but as far as direct outreach to those individuals in particular, that falls into DSS's process at this time.
So Shad, DSS owns these customers until they become Access Health customers.
But they are Access Health. I'm confused. They are Access Health customers, and they're Access Health customers now, and there's a problem because they were kept on because of the public health emergency. And so, I mean, I just need to understand it. I think what you're telling me, you're giving me the answer, which is that Access Health's responsibility with regard to these people who've been kept on during the public health emergency will be limited to the passive enrollment to see if that works. And if that doesn't work, it's going to be handed over to DSS for these Access Health customers to see if they can be found eligible under either that Medicaid category or some other Medicaid category. Is that a fair summary of the situation?
The passive renewal process is still owned by DSS. It's run in the Access Health system because we're integrated. Our eligibility process is integrated with Access Health for QHP and Medicaid. So that umbrella is all on one. When, as James mentioned, until those individuals enroll in a QHP, they're under the Medicaid kind of umbrella of customers. So Medicaid, DSS is responsible for that communication as far as their eligibility and coverage. Once they come in and enroll with us, then that's where we take over from our notices and messaging.
Okay, so
from the eligibility standpoint, they're all Access Health customers. But from the enrollment standpoint, this population remains a DSS.
All communications and their experience with communications for enrollment is with DSS.
Okay, so the passive enrollment is also DSS's responsibility. They're the ones doing that as well.
Correct. They're defining the rules, yes.
And running it. Okay. No, thank you very much. I didn't understand that. It's very helpful.
Okay.
Thank you.
It's not simple, so no problem.
Thank you, Sheldon. Great question. Kevin, you're next, and then Karen.
Okay, thank you, Ted. I have a couple of questions regarding the consumer outreach that's going to happen to these these folks who are terminated on 3/31. The first is the documentation that's going out, and this is just, I'm going to throw these questions out and chew on them or respond. The documentation that's going out, is it going to be consumer friendly? Is it going to be able to be taken in easily by people that may or may not understand this process? Because we're way out in the weeds on this stuff for a lot of folks to try to understand. The second is are there going to be language accommodations for these documents going out out to these customers? And the third is these documents going out, is there a chance that this group could see those and review them before they're released? Thank you.
I can chime in there. These documents are being produced by the Department of Social Services. In some capacities, they are sharing some information over with us for our review and input. So I can't say definitively without consulting with the Department of Social Services on whether or not we can share them with you. We can certainly ask that question and bring it back. So thank you for that, and we will do that. In terms of language preferences, I'll have to double check with what the Department of Social Services does. But I can tell you that if folks do call our call center, we have over 100 languages that are spoken by the folks in the call center. So if they do need language or help understanding this documentation, that is available to folks so that they can get that information in a way that's understandable for them to try and cross that language barrier. In terms of it being consumer friendly, we certainly hope so. And like I said, in some cases, they are asking us to weigh in. And we do everything that we can, at least from an Access Health side, and encourage them in what they're writing too, to keep language at a 5th grade level. And that is because that is what's generally accepted as the most plain language kind of bar, if you will. And so that is definitely what we try and do with all of our communications direct to consumers and of course, advising our partners over at the Department of Social Services as well. Does that answer your questions?
Yes, could I follow up, please? I guess from previous experience, both these comments are from previous experience. The first is we found in sending out documentation in the past that when some folks receive this, it becomes hard to read, they toss it. So I may be repeating Sheldon's question, but will there be follow-up post the document going out if we don't get a response from them? And the second is, I got to agree with Sheldon that DSS should have a seat in this committee, because we're talking a lot about DSS processes, and it'd make it a lot easier if they were here and could explain firsthand. And a couple of us on this committee have been involved in advisory committees in the past where DSS came to these committees late in the party, and a couple of times it was just plain ugly because of the difference in translation from one department to another. And again, this is just comment. I don't need a response, but those are my feelings.
Thank you, Kevin. Duly noted, well stated. Karen, you're up.
Sorry about that. Thank you. Just a couple of quick follow-up questions. So I'll just reiterate that I think having people review the documents would be important. I have said this to DSS as well. And while I think it would be helpful for folks like us who think about these things to review them, I think having members of Access Health and Medicaid review them is more important, because those are the people who know their own experience, and I want to just honor the lived experience of the people who are enrollees. And then just a couple of quick questions about the process. It does seem still very siloed for an integrated system, and I'm wondering what thought has been put into easing the transition for people, not just during the redetermination period, but writ large, right? We know this was a real problem for parents at the end of transitional medical assistance when Husky A limits were cut. And so what changes have been made or improvements have been made to smooth that transition to Covered Connecticut or a QHP for folks? And what, I saw the governor's proposal to add a checkbox to the state tax filings that would allow data sharing with Access Health, which is wonderful and hopefully will allow you to engage in outreach and gain some new members. But what thought has been given into, using some of the things that have been piloted in other states around easy enrollment in the system that you have as it is?
Karen, thank you for that question. We have been engaged at how looking at how do we auto enroll people into Comfort, Connecticut, so they wouldn't have to do anything at all. Right, and the challenges that we have in doing that, we can do everything up until them picking the plan. So then we want them to come in and update their information and pick a plan, because if after they update their information, they may re-qualify for Medicaid, which could be helping. Somebody may have had a child, or they may have, in addition to their fact to their household, that may re-qualify them for Medicaid. So before we enroll anybody into a Comfort, Connecticut or QHP, we really encourage them to come and update their information. All right, and but that's one. The other question, the other challenge for us is how do we pick a plan for them? So we have 2 carriers in the exchange. Actually, we have 3 carriers in the exchange. So Access Health would have to pick a plan for them. That's an area we're very concerned about. And also the Connecticut law only allows brokers to advise Connecticut residents in picking a plan. So by picking a plan with them, we would be potentially in violation of state law. Right, and so that's those are the areas that we're very concerned about. But also, the biggest concern we have is, and we're using data in our system that may be 2 or 3 years old, and to determine what they qualify for. And again, the biggest drivers of what they qualify for is income and family size of the household. If their income has changed, they have gone up, but they have a lower income in our system, and that's why they qualify for Comfort, Connecticut. And then when they do the taxes next year, they may have to pay all of that APTC back, because the income is higher than what we are using to project where they will land or what they qualify for. So we think that's our biggest concern. If, for example, if somebody right now, our system, so that the income level is at $30,000 and they're based on family size, they qualify for Comfort, Connecticut, the subsidy could be $1,000 a month. And somehow the income may be closer to $70,000 because they got a new job during 2022, but we didn't know that because they didn't come in and update their system, update our system. When they do the taxes next year based on $70,000, they will have to reimburse the federal government for most of that APTC, if not all of it. So that's why it's important to come in to update their information, so that we have the most accurate information to redetermine where they fall within the 3 categories and within the last 3 columns. Again, they may qualify for Medicaid. So that's why it's important. So again, those are the thoughts those are the discussions we've been having. How do we make it as easy as possible for them to come in and get to Comfort, Connecticut, while minimizing exposing them to any potential tax liability when they do taxes next year.
I hear those concerns, and I think they're valid. I also know that other states have considered and come up with solutions to all of these issues, including plan choice. And given that we're in the middle of a legislative session, if there are statutory barriers, I think now is the time to address them, because redeterminations not only are going to last a year, but in a year, you're going to have all of these people with their transitional medical assistance expiring, right? So I hear that this isn't a snap of the fingers, but it is a set of problems to which there are solutions that are already being put in place in other states. And I would really just urge thinking about trying to advance some of those solutions as soon as possible, because we know churn has a disproportionate impact on people of color. We know that these are people who are very likely to fall out of the system due to administrative burden more than anything else. And so, I just think let's use the tools that are available to us, including California's approach, which is not automatic enrollment, it's easy enrollment, it streamlines the process, it does not create any potential tax liability. So, I just would ask that you all to consider that and try to make some progress as soon as possible for folks.
So Karen, we are considering this. We have spoken with California. We also have looked at Rhode Island, which has an actual automatic enrollment into QHP. All right, but California is an opt-in, similar to what we do now. They enroll, they put you up to the line. They have to come in and opt into a particular plan. So we're doing the same thing California is doing now. Rhode Island actually puts you into a plan. But Rhode Island, as you know, has managed Medicaid. And the company that does the managed Medicaid is also on the exchange. So if you're coming off Medicaid during this transition period, they will put you with the same company that does manage Medicaid. Because the networks are the same and so forth. So they have, as you know, Connecticut doesn't have managed Medicaid. If they did have managed Medicaid, it might be in the same company was also in the exchange. It might be a lot easier to do what Rhode Island is doing. But we have explored both California and Rhode Island. We spoke with them extensively, and we are looking at different options going forward. How do we make it easier for our customers? We're always doing that. The option, the governors check the box on the tax forms. That's something that we've been working on with the Department of Revenue Services since last year. We got it done this year, so hopefully next year, within a year or so, it'll be a lot easier for Connecticut residents to get health insurance. If they check that box, then we get the information from DRS. We'll be able to see what they qualify for and do outreach to them directly to get them insurance if they don't have insurance.
Karen, any follow-up?
No, I appreciate you looking at it. And like I said, I think there's, the plan choice also, there's a number of creative options that I have heard about from policy experts. So, happy to discuss that further if that's something where you're interested in exploring.
Absolutely. We have discussed it with both carriers. They have given their input. So we're going through our process now, but if you want to send me a note or so, we could meet to discuss it in more detail. We are happy to do that.
Okay. Good. Let's move on then. Rebecca, if you're done, that's fine. If you have more for us, go ahead.
I will transition it over to my colleague Caroline.
Hi, good afternoon. Caroline Ruette here, the Director of Marketing for Access Health CT. We're going to continue on the conversation of what we're doing to support the Medicaid unwinding just now from the perspective of marketing. I do want to be mindful of time, so I'm going to go through this fairly quickly. Of course, if you have questions, I want to entertain those. But please note that my colleague, Tammy Hendricks, the Director of Health Equity and Outreach, is going to follow. And we do know that outreach is going to be really, really critical to penetrating this audience. So I want to make time for that. So I'm going to start by talking about what we're doing today. As Rebecca mentioned, we have been working with the Department of Social Services for more than a year to help with preparations. So where we're starting today and where we have been for the last several months is supporting a current campaign. This is a paid media campaign that DSS has in market. It's called Update Us So We Can Update You. And we've been amplifying this campaign and message through our own media channels. So our emails, as well as our social media, we're reposting a lot of their social posts and carrying this through our messaging where we can as well. And this is particularly important because we need to reach out to these people, right? DSS needs to reach out to these people and send them information that we've been talking about, those notices, those all important notices that are going to be going out to people. If we don't have their appropriate address because they haven't updated their address in the system over the last 3 years, that's going to be a huge issue. So we've been working, and not a fear-mongering way, but in a very positive way, urging folks to update their contact information so that we can get the most appropriate information out to them as soon as possible, whether that's DSS or Access Health CT. It's going to be a combination thereof. And then also, to a point made earlier, we have been invited by our partners over at DSS to review, provide input, and on some cases co-brand some notices that will be sent out to Connecticut residents impacted by the extension and unwinding, because of course they're going to have to come to the Access Health CP system to update their information. So we want to make sure that they're familiar with Access Health CT so that they can come and do that. Any questions here before we move on? Next slide, please, Martin. And then secondly, here I want to talk about a potential Medicaid unwinding advertising campaign. We are, first and foremost, we are working to secure funding for this, so we can't say exactly what it's going to include yet, but we will have a campaign in market, and we're expecting to launch this sometime in May. And that's because we feel like it's necessary to have something in the mass media, because to my previous point, there's a lot of contact information that's probably dated. And so if people are not in a residence where they were 3 years ago and we're sending them notices and they're going unread, right? We're not going to do any good. So there needs to be some type of state corner to corner coverage with this message. But more importantly, we do have data. It's not all bad. And so we can concentrate on certain communities that we know will have high populations of residents impacted by the Medicaid extension. And so how we're targeting these communities really follows the outreach plan at certain town levels and at a zip code level. And to get this off the ground, we've already started our creative brief with our creative partner and the different channels that we're considering. But of course, the funding on this will determine exactly where it goes. But just to give you a high level idea right now, we're looking at broadcast and streaming TV. Streaming TV are things like Hulu, if you're familiar with that, as well as YouTube TV, and that's something we can actually target at a zip code level, which is why it's important to consider broadcast as well as those streaming platforms. The same can be said about radio. Terrestrial is your typical AM and FM radio, and then the streaming radios like Pandora and Spotify can be targeted at a zip code level, so we're looking at that. We're looking at out-of-home opportunities, so think things like billboards, posters, as well as advertising at certain transit locations and actually on transit modalities as well. We're looking at newspapers, both minority as well as community newspapers across the state. Of course, social media can be activated at an organic and paid level. And lastly, a plethora of different digital types of advertisements, including search engine marketing. So if somebody goes into Google or Bing, those search engines, and puts, hey, I need Medicaid in Connecticut or something like that, that our results pop up, as well as having general advertisements in just the margins of a website based on certain zip codes again. So this is all still unfolding right now. We will work to keep you posted on exactly what funding is being secured and what channels we are going to be using, as well as the messages that we're developing. But really thinking that, you know, we have dated information from some folks and we want to make sure that nobody is left not knowing what's happening, that a mass media effort is needed here. Any questions?
I just had a question, Caroline, about the expected launch in May. Seems like that's a couple of months into the unwinding.
Yeah, we're approaching March. So we need to have the final funding secured. Then it's got to be, whether it's just Access Health funding this or whether we can actually work with DSS or potentially the Office of Health Strategy maybe to help fund this. There looks like there might be some money there that can help support it. We would need that in hand, and then our media buyers need about a month's time to go out and secure the placements before they can actually start. So they're going to need probably, if we get the funding secured within the next 2 weeks, we'll have it by April 1st so that they can go buy during the month of April, and it can be live in market by May. We'll go through the full time of the unwinding thereafter.
Kevin, go ahead. Kevin, do you have a question?
Yes, sir. Sorry. Yeah, I'm just going on this, off the question Ted had about the dates. So if these terminate on 3/31, they have April to put it sounds like to me that these folks have April to put together their ideas for what they want to do in the future. How do we, first, are my dates correct, the timeline? And second is, how are we connecting with them if we're not doing any kind of media work till May?
So my partner Tammy will talk about our in-person outreach strategy that will take place even prior to this campaign being in market. And quite frankly, is probably going to be more effective at moving these people into actually making decisions too, based on what we know about them and how they react to mass media. And we're at a point where we've been working collaboratively with a lot of folks. We've never done this before. And so we, have been putting plans together, trying to secure funding. It's not something that we were necessarily, we knew it was coming down the pipe, but we didn't know when. And so securing the funding has been the hard thing that's massively impacted our timeline here. That's truly been the obstacle.
Thank you.
Mr. Chairman, very quickly, Access Hub, we're committed to funding the marketing and outreach effort. Right? The other funding from other sources will determine how much we do. As I said at the last board meeting, we are going back to our board to ask for funding to come out of our reserves to support this effort, which was not part of our original budget. I suspect other agencies have the same challenges. They have to go and get funding, which was not part of the original budget. So we go back to our board probably in April to ask for additional funding. But we have already started creating as Caroline indicated, we've already started spending money in terms of creating the actual commercials and information that would be put out into the media. That's in progress now.
Okay, that's helpful. Thanks, James. Sheldon, go ahead.
Thank you.
Thanks. I did want to point out that, and I appreciate you said that you communicated with DSS about some of the notices. That's what it sounds like. You've worked with them on that, which is good to hear. But that doesn't address either Karen's question about getting input from consumers, or at least people directly working with consumers on the notices. And it doesn't address the concern that Kevin and I had about DSS being here at the table. So, I mean, sort of like as an advisory group, when we discussed extensively the need to have DSS at the table, and, sorry to rub this in, but the minutes we agreed to that we just signed off on, everybody was fine with the meeting, with the minutes said discussion followed regarding the addition of a rep from DSS as an ex officio subject matter expert on this committee to answer any questions that other committee members may have. Mr. Doolittle stated that engaging DSS with this committee will be under consideration. And I don't know what consideration was given, but they were not invited to come today. And I think that if we don't have them at the table, it's just going to continue to be this indirect thing. And Kevin did correctly describe past experiences. I think they should be here today. And I hope that going forward, this is going to stop. And we're going to have one knowledgeable representative from DSS at every meeting going forward. Otherwise, it's this completely indirect thing where we can't really have input. So I'm sorry about that, but I just feel that we've lost an opportunity here and time is of the essence. It should have happened.
James, could you directly address that, please?
Sure. So my apologies for this oversight on our part. However, going forward, we will invite DSS to these meetings, and we'll have a conversation with DSS tomorrow or Monday at the latest, and we'll make them aware of the questions that were raised today. And if need be, we will schedule a special meeting of this committee with the chairman's approval. So if DSS is available to be present and answer your specific question. All right, so hopefully it's not too late. If we're able to meet next week or the week after next, we just gotta clarify with them, request their presence, and we'll have a special meeting just for them to answer your questions that you raised today. But I want to stress that most of this committee's work will be to assist Access Hub, not DSS. Unfortunately, the medical unwinding is heading us now, so there's a DSS component to this. But the majority of this committee's work will be in the QHP space going forward. Normally, normally the amount of attention that is given to Medicaid redeterminations, we have a very limited role in that because all that happens through DSS. When people come back in to re-enroll, to update the information, they use our system. But usually all of that happens without our input. It just happens automatically. Then, but because we are part of the Medicaid unwinding, that is why this is part of this presentation. Otherwise, Medicaid without Medicaid unwinding, the redetermination that happens on a regular basis happens through DSS without our involvement at all. I just want to provide that clarification. So going forward, once we get to unwinding, I don't know how much DSS will need to be part of this committee because our discussions will be exclusively about marketing and outreach, as well as other processes that will help us to be more get more connected, more access to folks who are looking to enroll in QHP. However, if they may come to us, they may become Medicaid recipients based on information they put into our system. At that point, we pass them off to DSS. So that was helpful. I'll work with Ted, and I'll reach out to Commissioner Reeves and offer them an opportunity to provide somebody to come to this committee and answer the Medicaid or DSS specific questions about unwinding and communication strategies. And then hopefully I'm pretty sure they'll be able to answer the question, but I just got clear with Commissioner Reeves. And if so, we will schedule a special meeting of this committee rather sooner than later to address your concerns. But I have to first get clearance from the commissioner.
Okay, that's fair, James. I would say that I feel that the sense of this committee is that we should, in the near term, have some input and participation in these meetings from DSS. Now, that might not be permanent, right? But I think the Medicaid unwinding is in front of us and it's going to be front and center for at least the next several months. So to the extent it's at all possible, I think this committee is strongly urging and requesting you to ask Commissioner Reeves to send a representative to at least the next several meetings.
I'll get back to you, Mr. Chairman, and the committee once I get a response, and hopefully it'll be in the positive.
Okay. Thank you. We're going to move on to Kevin for another question. Kevin, go ahead.
Yeah, just a quick follow-up on the same subject, and I may be preaching to the choir, but as we reach out to DSS, one would hope that they're going to send someone who truly understands and can speak to policy or a decision maker. Again, from past experiences, when DSS has been involved, sometimes they've sent someone who is just taking notes and questions are answered by email later on. And I think we need a direct interaction. If this is in our face the next several months, to Ted's point, I think we need someone here that can really help us understand.
Yeah, and I think it's important because yes, this is DSS's show in many ways, but they don't have a committee like this one that is available to bring forward some of these concerns. So I think this is a good forum, even though it's not a DSS specific forum, to discuss Medicaid unwinding issues over the next several months. Thanks, Kevin. Okay, with that, Caroline, are you done? And if not, go ahead. If not, we'll move to Tammy.
Yeah, let's conclude our marketing session of the presentations today. Thank you. And I'll turn it over to Tammy Hendricks, our Director of Health Equity and Outreach.
Thank you, Caroline. Good afternoon. I'm sorry I was on mute when I introduced myself earlier. Tammy Hendricks, Director of Health Equity and Outreach. Really appreciate the great conversation today, and we will work closely with James to figure out how to get a rep from DSS, or if we can get a rep from DSS to participate in the next few meetings at least. So in-person outreach is the core to our department, really getting into communities, especially underserved communities, hard to serve, hard to reach communities, right? And our outreach stays consistent throughout the year. So since last year, we've been prepping our community partners, CACs, our brokers for the end of the Medicaid Unwind. So in terms of outreach, we have a few areas of focus that we think will make the most impact to the individuals on the extension. So this includes holding consistent meetings for our community partners, educational presentations for consumers, and of course, providing in-person enrollment opportunities for consumers across the state. So, but our plan really starts with a targeting, really begins with targeting specific locations, right? Outreach requires a lot of manpower and a lot of hours, so we have to be very strategic with where we are. So this is, and also how do we connect in a meaningful way to the most people possible, right? So with the help of Rebecca and her team, we're able to break down the Unwind population by county, which New Haven County takes the lead with the most individuals on the extension, followed by Hartford and Fairfield counties. From there, we wanted to focus on the towns and cities that had the highest number of users. And I just want to note the towns are not listed in order based on the number of users. They're just added under each county. So even though those focus areas, these are going to be the focus towns and cities for our outreach plan, we'll still maintain a presence in other cities and towns as well, just as we do in a typical year for outreach, right? We have areas of focus while providing resources to other areas as well. And so I also want us to keep in mind, you know, we are looking to reach a much smaller group of consumers based on the passive renewal process that Rebecca mentioned earlier. Still a smaller number, but still a significant number of folks. So our plan will stay flexible. We'll have to pivot probably a few times, revisit areas multiple times based on needs or feedback from community partners. But this is the list that we've come up with based on data, and that will be driving our plan for the year through the unwinding period. I'll pause here if you have any questions for this slide. If not, we'll move on to the next.
Questions for Tammy? If so, go ahead.
All right, great.
Tammy, go ahead.
Okay, great. So I wanted to briefly go through what we typically do for outreach because it'll serve as the framework really for the unwinding plan. And I know I've mentioned this before, but let's just go through it quickly. So when we get to the Medicaid unwind planning, it makes sense. So for right now, our team works closely with over 1,800 community partners throughout the state. This includes community organizations, other state agencies, religious groups, hospitals, FQHCs, really any organization that's interested in learning about health insurance through Access Health could be a partner. So when I say partner, there's not a specific group. It really is any organization that we've connected with, presented to, given resources to, or have trained. So I've listed a few partners on the slide just to serve as an example of the organizations that we've worked with over the years. But again, we work with over 1,800 community partners currently. So our outreach consists of a variety of activities. First, we have our monthly Healthy Chat presentations for consumers. The links are available on the Access Health website. This is a very high-level informational presentation for consumers to learn about Access Health, the plans we offer. We also get the opportunity to address any questions consumers may have or concerns during this call. And these presentations are really well attended. Consumers love it and they enjoy getting their questions answered by our team members. So again, the links are on the website. Anyone can join. We also do partner presentations. Any organization can request a presentation from our outreach staff, and whether that presentation is for their own staff or to a specific group that they serve, our team will happily accommodate and do an educational presentation for that organization. We also do quarterly regional planning meetings, which are held specifically for community partners, CACs, and brokers. CACs are certified application counselors that we train, and they're located in different organizations throughout the state. In these meetings, we share more detailed updates, right? As I mentioned earlier, we've been sharing information about the PHE Unwind since early last year, really prepping them, getting their feedback, and going from there. But we really wanted them to know what was coming ahead. And so we've been doing that since last year throughout all of our meetings. So right now, the focus really is reaching out to our current and new partners to go through our outreach plan for the Unwind and how we can partner with them to help the consumers that they serve and the communities that they're located in. So for example, we can offer training for their staff to become CACs. Or if an organization has space, we can do an enrollment fair there, or we can have an enrollment specialist and a broker on site to enroll consumers as they walk into those organizations. It could be as simple as having printed materials available to them for them to distribute. So we work with each organization, on an individual level to provide the support based on their requests and their needs. Next, we have our navigators. Our navigator partners, they help us with outreach throughout the year. They also provide in-person enrollment all year round. And while in the field, the outreach team, we also work with CACs and brokers. And CACs and brokers, again, are accessible to consumers all year round for enrollment. And they'll be really important partners as we move through the unwinding period. I've actually added a link to our community partners webpage that has a directory of all of our certified counselors and brokers that can provide enrollment assistance. So this link is available on the website. Consumers, anyone can go and find help close to their areas, in-person help. And I wanted to emphasize, I know James touched on this earlier, but legally only brokers can help consumers choose a plan. CAC can explain the plan options, but if a consumer doesn't know which plan to choose, they have to get referred to a broker. And this is state law. This is not an Access Health rule. So that's where the Broker Academy comes in for us. We currently have hundreds of certified brokers, but the Broker Academy is training new brokers in hard to reach areas, right? They know the communities, they know the members of those communities, so they're able to relate and really educate folks on making better decisions when it comes to their health insurance. So again, the last class, or the first class that we did last year, were located in Hartford, Fairfield, and New Haven counties. And so those are really, as you remember the slide that I showed first, those are the biggest counties that has the highest number of users on the extension. So this is just an overview of what we typically do in outreach, which will serve for the framework for the plan for the unwinding. And I'll pause here if we have any questions before moving on. Okay. All right, great. So this is the outreach plan that we came up for specifically for the unwinding, going for a year. There's a lot of information on this slide. So for the unwind, we're ramping up our outreach activities that I went through on the previous slide, right? We want to make sure we reach as many consumers as possible. Again, we'll focus on those areas with the highest numbers of consumers on the extension. We'll be doing more monthly presentations, healthy chat presentations for consumers. We'll do quarterly meetings for our partners, CACs and brokers, giving them updates, giving them materials that they can share. We actually have our first meeting scheduled for the end of next month. So I'll have more information once we solidify the locations for that. But most importantly, the biggest addition here is adding year-round enrollment fairs. And so typically enrollment fairs are only done during the open enrollment period. But the plan is to host fairs all year round in person to help those consumers, especially in underserved areas of the state where they may have questions about the notices that they receive. They may not understand the redetermination process because this is the first time that they're going through that. So we understand that. And so that's where outreach comes in. We provide that in-person help for consumers. And we know that a lot of individuals feel more comfortable doing the process in person. And we want to be able to provide that opportunity for the entire year. So our enrollment fairs, again, will be in addition to the in-person help that consumers can get all year round through our navigators, from our CACs, and from brokers throughout the state. I also wanted to add that we are launching year 2 of the Broker Academy. So consumers, again, in underserved areas will have more access to the help to get through the redetermination process and help getting help to pick a new plan if necessary. So we are really looking to ramp up starting next month. We'll start with our regional planning meetings. Hopefully we're looking into hiring more staff. But the key takeaway here is we're going to work on a deeper level with community organizations, having more consistent meetings, giving them more updates, materials, and possibly if we have the budget and the staffing, having enrollment staff at different locations or brokers to assist with consumers that may need help in different parts of the state. So that's really a key focus for us, and also educating consumers so that they're more comfortable going through the process. We're looking at this from all different angles. So I just wanted to reemphasize that, you know, all of these efforts, it's not going to be done by one organization. It's not just going to be Access Health. We have hundreds of community organizations that will be a part of this, that we're updating, that will help reach some consumers that they serve. And so lots of efforts happening on multiple levels here. We have marketing, we have outreach, we have community partners helping. So, you know, I think we have a really good plan in place, and we are going to reach as many people as possible. So I'll end my presentation there if you have any questions, so I don't ramble on.
Questions for Tammy? Karen, go ahead.
Yeah, this is maybe a little bit tangential, but just because all these things are happening at the same time, one question I've been getting is around call center training and whether or not the Access Health Call Center has received training on new eligibility categories for Husky for Immigrants. We're hearing just anecdotally from some folks in the early days of this being rolled out that they've reached the Access Health Call Center and been told that there is no eligibility for immigrants without documents, or been given other false information. And we know that the immigration rules are really complicated and that this has always been an issue. It's not a new one. So just curious what you've done to kind of help folks get up to speed on that.
Yeah, so call center reps are absolutely trained. And CACs and brokers are also trained on a yearly basis. They have to go through our trainings to recertify. So if you have any specific examples, Karen, I'm happy to take a look at it, but our call center staff are trained extensively.
Karen, the training that our call center reps get, our collaboration between Access Health and DSS. So in anything involving Medicaid, DSS provide us with the curriculum, and they even have trained our trainers. So it's done appropriately. They provide their own review. And anything involving QHB, Access Health, we do that. We come up with our own curriculum. But anything at all that is going on where Medicaid programs are going through the exchange, yes, our call center, as well as brokers, as well as CACs, are all trained on everything on the exchange, including Medicaid programs.
Rita, I was specifically asking about the Medicaid for immigrants, because so when we did focus groups on applications and renewal processes prior to the pandemic and prior to there being eligibility for undocumented immigrants, we heard a lot of concerns about people getting incorrect information about eligibility for immigrants who would be eligible. And I'm hearing the same concerns now in the last few months now that eligibility for children and pregnant women has begun. And I just wanted to raise that and hear if you're hearing the same thing and if there's any kind of plan to provide maybe some extra information around that specific set of issues.
We'll certainly take that back and talk with our call center folks and have them review the training around those particular areas. I know they are new programs, and I like James said, what DSS is managing that those updates to the training. It potentially could just be a timing thing where those particular reps hadn't had a refresher, but we can certainly bring it up to them and have them check. And you know, put out some refreshers or just focus on that area.
And
I think that's
Karen, all of our calls are recorded, right? And so we could pinpoint specific calls by type of calls and time of day. So we go back and listen to what was said, how it was said, and retrain those folks who are maybe putting out wrong information. But again, as Rebecca said, we're gonna go back and look at it and come back to this committee in a short order of time to give you an update on what happened and more importantly, what we have done to minimize it from happening again.
Appreciate it. Thank you.
Thanks, Karen. Deb, your turn.
Hi, thank you for this. And it looks very comprehensive, a little overwhelming, and I'm sure it is for you as well. One of the things that I've been thinking about is trying to reach people when they're not thinking about accessing healthcare, when they're not thinking about renewing insurance or finding new insurance. And there are certain points in the year when predictable things like that happen. For example, the Volunteer Income Tax Assistance Program, VITA, operates typically February, March, April. So people are coming into locations with their income information already. And that could be a good time to talk to folks about health insurance. Back to school time of year, August, September, there are often back to school fairs or open houses across in each of our cities and towns. Energy assistance usually starts in September, sometimes even August. So people are coming in to get enrolled in those programs. So just thinking through what are the predictable events that occur each year where you're going to have people walking in and maybe not thinking about healthcare, but you could grab them and educate them and provide some outreach.
Yeah, thank you for that. And that's absolutely what we do. So the previous slide, I believe I had a DPH, the little vaccine van. And just as an example, we worked with DPH since the pandemic started, and we would set up a table at the clinics. Of course, you know, after you get vaccinated, you have to sit there for 10 to 15 minutes. And so we were capturing a lot of people that way too. So we absolutely thinking those lines, Deb, and I like the VITA idea, and we'll definitely take that back. But we're out there for outreach events all the time. We're happy to take any new events that may come up that you may think of that we can be a part of. We would absolutely take you up on that. But that's how we really focus on outreach, is where those consumers are already going. And our navigators play a really important part in that, right? Because we have navigators who offer energy assistance. So they're already seeing those consumers that are coming in, and they're able to help them with energy assistance, food or whatever, housing, rental assistance, and also being able to offer the enrollment if they need health insurance. So the navigators kind of fill that in for us, but yes, we absolutely do think along those lines. So if you have any suggestions, we'll happily take them.
Super, thank you.
I just want to echo that that's an excellent point. I actually took some notes about the things that you were rattling off to see if there's any marketing opportunities too. Something that we're doing and experimenting with right now, especially given the Medicaid unwinding, but this can be potentially helpful for us too in other years. We're working with the DMV. They have opportunities to advertise, as people, you're sitting in the chair, you're a captive audience, right? Similarly to what Tammy was talking about. with the vaccines. And people have to go to a DMV in Connecticut for certain things that actually kind of align really well with qualifying life events that would trigger an open enrollment period out or a special enrollment period outside of OE in a typical normal year. Right, so there's a need for it right now, but also it could be helpful for us in the future. So some of those things are moving to the state. If you get married and you change your name, right, those are all qualifying life events and not something that you can renew online. You have to physically go to a DMV location to do that. As a recently married person that had to change my name, I'm not gonna lie, it really struck a chord with me. And so I said, we gotta see what we can do here. So as any of those ideas come up about how we can catch people in the moment when they are a captive audience, this is a great place to share that and for us to take action. So thank you for that.
Okay, thanks. I appreciate the team's openness. This committee has a deep range of acquaintanceships and activities that we're involved in. So keep Access Health in mind. If you see an opportunity, it sounds like Tammy or Caroline or both are really eager to hear the new idea. So keep those coming. We're going to have to end the question period for this topic and move on to item F now. Future agenda items. James, go ahead, please.
Quickly, just want to make this committee aware, as we develop our marketing materials in the near future, we would like to share them with the committee before we finalize them to get your input and guidance. Though because of time constraints, we would probably have to have a quick turnaround. All right, so we are working with our vendors to create the materials that we are about medical unwinding, whether it be TV or print ads or radio. We will get them to you quickly as possible, but we would ask for as quick a turnaround as possible to get your input or guidance, any suggested changes that could be helpful to us as well. As you create materials for marketing, from outreach as well, we will share with this committee. This is before we make them publicly available, just to get your input before we finalize and start printing and start distributing them. So again, that's one future area that we would hope this committee would be very helpful to us, making sure that the message is clear, is accurate, and is on point.
James, that's wonderful. Now, is that type of activity have to take place around a meeting of this committee, or would you be circulating things in between meetings, or both, or what?
I think, Mr. Chairman, we'll get them to you, and we'll get them to March and send it to the whole committee to get their input with some timeline for return input. Again, I don't think we need to meet just for that, but we will circulate with the entire. We will circulate them with the entire committee for their input via email.
Okay. If we're going to discuss any of these at future meetings, I would just make a request that you flag that for folks so they know they have a little bit of homework to do coming into the meeting. Obviously, people review the materials with great care, I know, but if there is something you're seeking specific feedback on, such as a new communication, please just bring it to our attention so people can give that special early attention. Anything else on what James just brought up? Hearing none, I would solicit a motion to adjourn.
So moved, Deb Poland.
Moved by Deb Poland. Is there a second?
Holly Hackett, second.
Holly Hackett, second. Motion to adjourn is not debatable, so we're going to have to move directly to a roll call. Go ahead, Martian.
Peter Luludo.
Yes.
CC Woods.
Yes.
Deb Poland.
Yes.
Sheldon Taubman.
Yes.
Kevin Galvin. Karen Siegel. Giselle Carlotta McDonald.
Yes.
Leslie Greer.
Yes.
And Holly Hackett.
Yes.
Thank you.
Thanks, everyone. Bye-bye.
Thank you.
You.
Bye-bye.